I'm Rose Boron. My colleague, Robin Fisher, and I will be presenting this unit of the Helen Bader Foundation CBRF Caregiver Training Program. The unit is entitled Challenging Behaviors in the CBRF. The information and material that we will be presenting is taken from the book Understanding Difficult Behaviors. This book is written by Annie Robinson, who is a nationally recognized specialist in dementia care. Before we begin our time together, we would like to remind you to read your workbook thoroughly. Our program does follow the general format of your workbook, but because Robin and I are both caregivers, we will be sharing personal experiences that we've had with residents that have dementia that we've worked with through the past. We share these experiences to help make points with you that you can understand the directives. We will start the Challenging Behaviors unit with a pre-test. You will be asked to take the pre-test at the beginning of the unit. The response to the pre-test will not be revealed until you have taken the post-test. The pre-test and the post-test will help you to identify important points that we will want you to understand at the completion of this unit. Your responses to the pre-test and the post-test will not be graded. Please feel free to make notes in your workbook throughout the program. Now, please turn off the videotape and prepare to take the pre-test. Welcome back. Let's get started. As caregivers in a CBRF, it's very important that we have a basic knowledge of some of the challenging behaviors that our residents will present to us and their possible causes and what we can do to prevent those behaviors or problem solve them. First of all, what are some of the behaviors that we see? Well, they can include, but not necessarily be limited to, wandering, agitation, incontinence, swearing, screaming, striking out, maybe difficulty with bathing, refusing assistance with dressing, eating, repetitive actions, hoarding, and taking things that don't belong to them. And these are just a few, and I'm sure that you could add several more to this list. As we look at these challenging behaviors and others, it's very important that we remember the effects of dementia are very individual, and that these behaviors that I've just mentioned change from person to person. And as I said, there are many challenging behaviors that the person with dementia might exhibit to us. And as many behaviors as there are many reasons for these challenging behaviors that we see. Some of the reasons might be related to the changes that are taking place in the brain, or other causes related to the physical and emotional health of the resident. There are causes that are related to the environment, causes related to what we're asking a resident to do, or causes related to communication, we to them and them to us. Maybe it's problem-solving skills, our problem-solving skills, or their lack of ability to problem-solve because of the changes in their brain. I'd like you to put a star in your workbook next to this statement. There are 4 basic causes for challenging behaviors. Now, I'd like you to put a question mark in the margin. And then I'd like you to remember to ask yourself, each time you see a challenging behavior, is this behavior related to the residents, and this is what I want you to write, physical or emotional health, the environment, the task or communication, physical or emotional health, the environment, task, or communication. We'll be discussing these 4 categories in detail today, and I think you're going to be very surprised at how important a role they play, both collectively, all together, and individually, in terms of how the resident presents behaviors. Robin will begin with causes related to the resident's physical and emotional health. Robin?
Thanks, Rose. 4 possible causes of challenging behaviors have been identified. The first cause could be related to the resident's physical and emotional health. Residents with dementia suffer an ongoing brain damage that can affect behavior. Residents with dementia can also have other medical problems that can greatly affect their behavior. In your notebook, you will notice we have identified some of the more common physical problems that caregivers should be alert to. The effects of medication. Residents with dementia can be very sensitive to over-medication and react to combinations of medications as well and their side effects. Drugs also can cause confusion and changes in a resident's level of functioning. Falling, drowsiness, sudden increases in agitation, strange mouth and hand movements may be side effects of medication and should be reported to the physician immediately. Impaired vision and hearing. Both impaired vision and hearing can affect a resident's ability to understand what is said to them. It is important that the resident is evaluated by a doctor, and if possible, hearing and vision problems can be corrected. Severe illnesses such as urinary tract infections, pneumonia, fever, and other illnesses may cause increased confusion. It is not always easy to recognize severe illness with residents with dementia, since they are unable to tell you their symptoms. Any sudden changes in behavior, such as a very sleepy person who has always been an active wanderer, should be reported to the doctor immediately. Chronic illnesses such as diabetes or congestive heart failure can affect a person's mood or level of functioning. Chronic pain such as arthritis can also have the same effect. Many residents do not get enough fluid and become dehydrated. They no longer realize the sensation of thirst and forget to drink. Residents should be offered fluids throughout the day. Symptoms of dehydration to be aware of are dizziness, confusion, refusal to drink. Skin may appear dry and possible flushing and fever and a very rapid pulse. Constipation can be uncomfortable for residents with dementia as well, and impactions can lead to delusional behavior. Often it is very difficult to notice if a resident is depressed or affected by their dementia or both. Some symptoms of depression are memory loss and sleep disturbances, as well as impaired concentration. It is important for a resident's doctor to be aware of the symptoms and to do a complete evaluation for depression. Fatigue, tiredness, exhaustion can disrupt sleep patterns and cause an angry or agitated behavior. In addition, if the resident's immediate needs are not being met, they may be in physical discomfort. Rose will now discuss environment, task, and communication.
Thank you, Robin. Now, let's take a look at the environment. An important point to remember about challenging behaviors is you cannot control the resident's behavior. You can only control your own behavior. What you can control, though, is the resident's environment. And your having some control on the resident's environment can have a very positive impact on their behavior. The physical environment, that is the space that the resident finds himself in, can be the cause of increased confusion, agitation, and restlessness. If there's too much clutter, the resident may not be able to absorb it all. It may increase his confusion and make him more agitated. Again, it might send messages to that his brain is unable to handle. Whenever possible, simplify the environment so that the resident with dementia is not overwhelmed. What can happen when there's too much stimulation? Before you start thinking an answer to that question, let's just look at stimulation. What is too much stimulation? Well, too much stimulation can change from person to person. One resident may be able to absorb or tolerate more than the next, just like you and I. How much is too much? A good example is when there are a number of things going on in the same room at the same time, it's often too much stimulation. Let me share an example with you. Some time ago, I was called to a nursing home to do a behavioral assessment on a resident who was experiencing acting out behaviors, striking out behaviors. Now, this nursing home did not have a dementia unit. They mainstreamed their residents with dementia throughout the nursing home, just like most of our CBRFs do. And I was observing this resident as he sat in the corner of a very large activity room. I watched him and I listened, and what I saw and heard was this. In one corner of a room, a bingo game was being played. 6 or 7 residents sitting around, and another resident with a loud, booming voice calling B1, B7. In another part of the room, a small group of residents were sitting in wheelchairs in front of a television set. That on the TV was a video exercise program, and the tape was on rather loudly. And there was a senior volunteer, and she was saying, "That's right, kick and move and lift those legs," and loudly. In another area, residents were watching a cooking demonstration, and this was a quiet demonstration until the staff person realized that the muffins were burnt to the pan, and she began to pound the muffin pan on the counter. Add to that the PA system, the public address system, announcing every few minutes, "Mrs. Smith, please take the call in your office. Mrs. Smith." And one last thing. The bathroom call system was hooked into the PA, the public address system, and every time a resident pulled a bathroom bell to call for a staff member for assistant, it went out throughout the nursing home in a loud, persistent buzz, buzz, buzz. Now let's recap that. Bingo, exercises, pounding the muffin pan, the PA system calling Mrs. Smith, and the bathroom buzzer ringing loudly. And then a staff person approached the resident. And she did everything correctly. She approached him from the front. She made visual contact before she made physical contact. And she was lucky to get out of the way just fast enough so that he missed her when he kicked out at her. And the cause for this acting out behavior? Too much stimulation. The resident with dementia has lost the ability to tune it out. He hears all of the background noise all at once, and probably understands none of it. And he is frightened, and he's frustrated, and he's anxious, and he's angry. Add this to the fact that a stranger now is approaching him and wanting him to get up and get out of his chair. And all he has left to rely on is his instinct. Being in a strange place, a loud and noisy place, not recognizing anyone around him, he has only one thing left to rely on, and that's his internal instinct to protect himself from being overwhelmed by strange noises and strange people. Think about it. Wouldn't you do the same thing if you were in a strange place and it was very loud and there were different noises coming from everywhere, even out of the walls and the ceilings, surrounded by people that you have never seen before, doing things that you don't understand, and now some one of them is trying, you think, to hurt you? I would guess that you might strike out as well to protect yourself. I think I might. And all of this could have been avoided if the caregiver would have taken control of the environment. Remember, think about what's going on before that resident's outburst. Is there too much noise? Are there too many people around? I would suggest that after you've completed this program, you take a tour of your facility. Look around closely. Are you providing cues for the resident, information for the resident about his environment? Remember, every day our residents find themselves in a strange place. Sometimes just a turn of the head, looking in another direction, can completely disorient or confuse them. As your residents progress with dementia, they need to have the environment support them. They need familiar things in their environment to tell them where they are and what they're doing, and sometimes even who they are. And that's called residential character. Residential character is providing cues and information about the environment. Any room that a resident finds himself in or has access to in your CBRF should have residential character. Some examples of residential character. Let's take the dining room, for instance. There should be a tablecloth or a table runner or placemats or flower arrangements on the table. There should be pictures on the wall that are appropriate to dining room pictures. We have a hutch in each of our dining rooms, and they're big and they're sturdy and they're full of dishes, and if they get bumped into, they don't fall over. And the hutch isn't really used as a hutch except to send a message. The message that it sends to the resident is, this is where I eat. There's the tables, there's the hutch, there's the dishes in it, and this is where I eat. Another question for you. How many of you only decorate your bedroom in your home? That's the only place that has a little flavor of who you are. I know that's a silly question. But why should it be any different for a resident with dementia in one of your facilities? They probably spend very little time in their room. If they have a favorite chair, that favorite chair should be out in the living room. If they have a favorite Afghan, that Afghan should be out on their chair in the living room, not folded neatly at the end of the bed or not folded neatly in the closet, but again, out in the living room. If they have a cherished family photo, it should be next to their favorite chair and at the resident's eye level when he's sitting. The resident might not be able to tell you who those family members are, but looking at it might give him a feeling of security, a feeling of control, a feeling of comfort, a feeling of belonging. And that's what residential character is. Now, I'd like to give you 2 examples of residential character that we learned firsthand. We have a resident that came to us who was obviously a resident that had no nutritional problems, had a very hearty appetite. She had been with us for 2 or 3 days, and we began to see a change in her appetite. And we're really trying to understand what it could be. And we thought it might be the relocation process. She was no longer in her own home, and she was having some difficulty adjusting. Well, after 3 days of very poor appetite, we called the family and said, can you give us some more ideas? We've tried everything that they had shared with us in the pre-admission assessment in terms of what her favorite foods were, what her time of day to eat was, those kinds of things. And the family came in and said, you know, where does she sit to eat? And the daughter said, well, that's simple. Mother has always had a picture of the elderly man and woman praying hands over bread hung above her dining room table right on the wall where she ate. She took this picture with her in any house that she had ever lived in through her whole married life. The daughter brought that picture. It was that simple to give her residential character, to cue a memory for her that this is where I eat, this is where I belong. No further problems with difficult behavior or her refusing to eat or come to the dining room. Another suggestion was a resident that came to us that was continent of bowel and bladder, no difficulties. After being there several days, was very resistant to our trying to help him, refused to allow us in the bathroom, was incontinent several times a day, and become very restless and agitated as a result. Again, we looked at our pre-admission assessment, at our individualized service plan, and said, what haven't we tried? And we had gone through all of it. We called the family, and the wife came in, and what she brought with her was a picture of his farm, an aerial picture taken of his farm, and his magazine rack that sat in his bathroom next to the toilet for all of his adult life, because part of his routine was to sit down and read a magazine. As his dementia progressed, he only had the farm catalogs that he would look at, but that's what gave that room residential character for him. That's what cued him. That was his long-term memory that helped him to know what that room was for. For some residents, it's helpful to put their name on their bedroom door for them, while others might need a photo of themselves when they were younger, because most often our residents recognize themselves when they were 26 years old and see the current picture of themselves as their mother or father. Sometimes a reminder of what they did for a living is helpful on their doors. We have a lady who was a seamstress. Her specialty was wedding dresses. We purchased several Barbie doll wedding dresses, put them in a frame, and hung them on her door, and that cued her to what her room was. For another resident, it was silk roses on her bathroom door, because you see, she was a very proper lady, and she'd never had a bowel movement in her entire life. She always referred to it as smelling the roses. And by putting the roses on her door, on her bathroom door, we gave her a cue. We gave her important information about her environment and relieved her of the stress and allowed her dignity to remain intact. As our residents age, their ability to hear, taste, and see and smell is diminished. A simple thing like lighting can affect a person's behavior. Inadequate lighting can cause the resident to see shadows or intruders or animals on the wall. Patterned tiles on the floor can look like holes, and as the resident attempts to step over the holes, he may fall and injure himself. Glare from a highly polished floor can affect the resident's ability to see. Reflections in a window at night can cause the resident to think that there's someone outside looking in at him and greatly affect their behavior. One of our residents was going to throw a chair through a bay window because he saw an old man outside, and it was winter, and he knew that old man must be cold and hungry and tired. This gentleman was a retired firefighter, and in the reflection in the window that he saw was really himself. But his long-term memory, his memory from 50 years ago as a firefighter, told him, if you have no other way to rescue someone and all that's between you is a pane of glass, you must break the pane of glass. Needless to say, all of our blinds are now closed at night as soon as it begins to be dark. Residents with dementia do not do well in unstructured environments. They need schedules, they need routines, a routine that they can depend on and help them to reduce their stress. But keep in mind, we must be flexible in your daily routines to allow for the residents' changes in moods and behaviors. The next category that we're going to talk about is tasks. What you're asking or assisting the resident to do. Sometimes it may be too complicated or it might have too many steps. The one thing that you're going to do when that happens is overwhelm the resident. And how does he respond? By being resistant, by being uncooperative, and depending on if you continue to persist that he continue with the task, he may strike out at you. He may get so frustrated that he refuses at all to be involved in what you want him to do. It's important that we remember to break tasks down to simple steps. For example, you've just told the resident that you want him to brush his teeth, and he looks at you like he doesn't know what you're talking about, and you're thinking, how hard can it be to brush your teeth? That's not a real complicated task. Let's walk through that. First of all, he needs to understand what you're talking about. Then he needs to find his bathroom, turn the light on, find his toothbrush, find the toothpaste, take the cover off, and that might include pulling or twisting. Squeeze the toothpaste on the toothbrush, the right end hopefully. Turn the water on, put the brush under the water, bring his hand to his mouth, and then start the brushing movement. How many steps was that? About 14. 14 steps just to brush his teeth. Now, how could we break that task down? I would suggest waiting until after his cares are done, and he's in his pajamas if this is a brushing teeth at nighttime, and give him about 10 or 15 minutes after he's completed the undressing and the partial bath. Give him that time to just relax. Have everything you need to complete that task. The toothpaste, the toothbrush, the glass of water, a hand towel to dry his face and hands when he's finished. And then say to Mr. Kelly, would you like to come with me? And offer him your arm. Don't take his arm and lead the way. Because if he doesn't know who you are and doesn't know what you're asking, he isn't going to know where you're taking him. And when you're leading the way, if you're walking just a bit ahead of him, he's losing the control of the situation. And how might he respond? Right. He might be resistant. He might be suspicious. So now what we want to do is follow these steps. First, you want to gather everything you'll need. You want to invite him to come with you. And you want to allow him the choice of taking your arm. And you'll walk to the bathroom and say to him, here's the toothbrush. Now, if he can squeeze the toothpaste still on the toothbrush, you need to allow him to do that. You could turn the water on for him. You can show him by your gestures that you want him to put the toothpaste under the water. You may have to show him by your gesture that you want him to start brushing. Sometimes hand-over-hand assistance is required. Well, you will gently put your hand on top of his and help him to start the brushing routine. Sometimes that's all it's needed to trigger in his brain what needs to come next. His remote memory from years ago will be able to complete the task. Sometimes you need to take it one step more and actually brush his teeth for him. One step at a time, slowly, never rushing, never overwhelming. If we combine steps, skip a step, or move too fast, it's too confusing for the resident. This also might apply with the resident who is eating, or you want to eat. If you say to her, come on, Mary, come with me, Mary, we'll go down the hall and into the dining room, and we can eat lunch. Hurry now. What have you told her? Come on, go down, into, eat, and hurry. Does that make any sense? That might be all that she's heard you say. Those may be the words that she understands, and think about the mixed message that you've sent her and how jumbled up that message is. For example, another example would be to say to Mary after she's sitting down in her chair, here's your lunch, Mary, here's your milk and your fork and your meat and potatoes, and the corn is on this side, Mary, and here's your bread, and here, let me help you with your napkin. And as you're walking away, you may say, oh, Mary, enjoy your lunch, and you walk away. Thinking, I've done everything the way I should, and poor Mary has no idea what you've just said, and may not even recognize a fork or what it's used for when she sees it in front of her. Or she doesn't know that she needs to pick up the fork, stab the meat, and bring it to her mouth and start chewing. So she might just push the food away, or push it off the table entirely, or just sit and refuse to eat. All because we have combined too many steps and overwhelmed her. We all know that as dementia progresses, residents lose their ability to start a task. In that situation, it's important that we adjust our tasks to meet their abilities. How do we do that? Well, when a resident first comes in, he may be able to dress himself if we lay his clothes out in the sequence that they go on. Whatever goes on first would be on the top of the pile. Then he may progress to the point that we need to hand the resident his clothes because he isn't able to put them on in the right order or right sequence, meaning that he could put his pants on and then put his underwear on over the top of his pants. He still understands how to do it and still can do it, but doesn't know the order. So we need to adjust our caregiving, again, to meet his remaining skills. It would be easier and quicker for us to do it for him, but better that he's able to be as independent as possible for as long as possible. And eventually, you're going to be doing it all, and he may only be able to zip up his pants. And if that's all he can do, then that's what he should do. If you're following along in your workbook, the next topic that we're going to cover is communication. Communication between us as caregivers and the resident with dementia is very important. The resident with dementia may be angry or agitated because they don't know what's expected of them, or because they feel frustrated that they can't understand you and they can't make themselves understood to you. Causes for poor communication or better communication will be covered in the Let's Communicate unit. And now Robin is going to be talking to you about problem solving. Robin?
Thanks, Rose. Let's follow up with problem solving. When you're faced with a challenging behavior or situation, try to understand why that behavior is happening. What are some of the things which may have triggered that behavior and what can change? It is important that you recognize things in the environment, the medical situation, or the problems in communication that might add to the problem. When does the problem occur? What time did it happen? Who was involved? And who was affected? What was the emotion expressed by the resident? And how did the caregiver respond? Keep a log of the problem or situation. Try to pinpoint specific causes. Remember the categories. Is it physical or emotional health? The environment? The task or communication? Develop a list of responses to the behavior or specific situation. Be creative. Have someone else look at the list and give you suggestions. Review the list. Decide which of the responses you will try first. And don't worry if it doesn't work. You will still gain a lot of information on that particular situation and behavior. Problem solving is always by trial and error. There never is a simple solution. Sometimes your solution works this time and it may not work the next. Each resident is very individual. After the situation has been resolved, reassure the resident and let them know that you care. Always remember, the behavior is caused by a disease of the brain. The resident is not trying to be nasty, disagreeable, or do those things on purpose. Finally, don't do it alone. It's okay to ask for help. Get together with other caregivers, exchange ideas. Rose will now follow with challenging behaviors.
Is this right? Am I doing it right?
It's fine, Mr. Brown. You're doing a good job.
I can't do it! It isn't right, I can't do it!
Mr. Brown, why did you throw that brush? You're acting like a child. Now sit down and behave.
Don't tell me what to do!
Sit down now.
I can't do it! It isn't right, I can't do it!
Mr. Brown, I can see you're upset, but we can't allow this kind of behavior. Let's walk over here and sit down, and you can tell me about why you're upset.
Get out of my way!
Okay, then, let's just walk around.
When we began this segment, we listed some of the more common, angry, agitated behaviors that we might routinely see. And we also listed some of the possible causes: the resident's physical health, the environment, communication, and tasks. Let's look at angry, agitated behavior and what, if possible, causes and solutions we can find. Let's look at the physical causes. Is the resident tired when you're asking him to do something that's late in the day? Are they just not able to cope with what you want them to do? Has their sleep pattern been disrupted? Has he been up half the night? Has he only slept for short periods during the night? I bet that you and I would be tired and irritable and not real cooperative if that's the kind of night that we had. Someone with dementia may not be able to tell you that they're in pain. In fact, if I were 88 years old and had a urinary tract or a bladder infection, what would be the first sign that you might see? Would it be a slight elevated temperature, or frequent urination, or complaints of burning upon urination? No. The first steps that you would see would be changes in my behavior. I would be irritable. Maybe I wouldn't want to eat. I would be restless. I might be weepy. And if I was constipated, I might not be able to sit for long periods of time. I would be up and down. I would be moving about rapidly, or as rapidly as I could. I would be restless. Remember, I have lost the ability to recognize pain, and the message is getting lost before it gets to my brain. Oftentimes, as a result of medications, a person with dementia can be very agitated. Maybe it's too high of a dose, or the wrong symptoms have been described to the doctor, and maybe a wrong medication has been ordered. Sometimes it's a result of a heart medication, or their blood levels aren't being monitored frequently enough. The doctor doesn't get the correct picture and changes that are necessary aren't being made. What happens with vision? Well, it stands to reason if a resident can't see you or only sees shadows because of poor vision, the resident is going to be anxious or frightened of what he thinks he sees. The same behavior might be caused because the resident is already confused, and now he has a hearing loss, and he understands even less of what you're trying to say. Sometimes residents have hallucinations, seeing things or hearing things that only they can verify. What in the environment can cause angry, agitated behavior or disruptive behavior? Overload, too much noise, too much activity, too much clutter, too many people. Sudden movements, someone coming up from behind and taking the resident's arm and turning him around quickly with no warning. Poor lighting, or adjusting from darkness to light. Adjusting from carpet to linoleum can be frightening for them. Other causes of agitation or angry behavior is being asked to respond to too many questions at the same time, or the residents reacting to arguments between other residents, or responding to what's going on television. Residents may respond aggressively to the direction you give if they feel that they're being scolded. Remember, if you change their routine or task in the middle of it, or if the task is too complicated, the resident may respond aggressively. What can we do to find answers? How can we problem solve? First of all, in this situation, we want to call the doctor. We want to describe the symptoms, review the resident's medication with him, make sure that their routine is quiet. Make sure that you offer redirection. Make sure that you give them snacks or maybe soft music. Use good communication skills. Don't ask the residents questions that begin with, "Do you remember?" And doing that, you're setting them up to fail. Don't try to reason with the resident. If they're wrong, and you know they're wrong, you're never going to convince them of that, and you're going to make them more upset in the process. Don't ever express your anger or frustration verbally or by your body language. Remember, the resident reads your body language long after they've lost the ability to understand the words that you're saying. It's important to speak slowly and clearly. Don't talk down to them in a condescending tone. Always approach from the front. Always have the resident's attention before speaking or touching them. For tasks, don't hurry. Limit their choices. Don't overwhelm them. Give clearly stated directions. One of our residents fell and broke her hip when the staff person said, "It's time to hop into bed now," and she literally tried to do that. In your CBRF, a consistent staff means residents developing trust with the staff. A consistent staff means you're knowing your residents and when they're restless and what you need to do for them. You'll want to share ideas and approaches with other staff. Tell them what works and tell them what doesn't work. And if the resident who is wandering at shift time, be sure that the shift change is a quiet one. No loud and noisy goodbyes. Staff shouldn't be walking through the building with their coats on saying, "We'll see you tomorrow." If you do that, what message are you sending the residents? The message is, the day is over. It's time to go home. And is it any wonder that they might want to get their coat on at that time and attempt to wander or go out the door and then be difficult to redirect? If you feel that you're in danger with a resident who is angry and agitated, stand out of his reach or walk away. Call for a coworker for help. Call the police at a last resort, because a uniformed officer oftentimes makes the resident even more agitated. When the resident is calm and the crisis is over, don't remind him of it. Don't try to talk it through or problem solve with the resident. Your facility should have an emergency procedure in place in the event of a catastrophic or loud, abusive, assaultive resident reaction to you, so that in the middle of a crisis, you have something to look at that will tell you, this is what I need to do next, and this is the next step to follow. Our next category is hallucinations and paranoid reactions.
Some people came to our house last night while we were eating, and they stayed all night. They're taking up all of my husband's time, and I don't like that. They're talking about me. I can hear them.
I know you think you have visitors, but I'm not aware of them. I see you're upset.
They're taking up all of my husband's time, and he doesn't have any time for me.
I'll talk to your husband, Mrs. Miller. Now, we're baking chocolate chip cookies, and I'm sure we could use your help.
Oh.
How was your granddaughter's birthday party?
Oh, it was really wonderful. But were you there?
I don't think so.
Did you have cake
We had cake with my...
and vanilla?
Your favorite. We had cake, too.
Did you have ice cream?
Did you come to that party?
I don't know.
Oh.
I don't think so.
I know I had my glasses in my purse when I left home. Now I need them, and they're gone. Somebody took them out of my purse. I know somebody has stolen my glasses.
You left your glasses at home. Nobody here would steal your glasses. You're the only one who's had your purse.
Don't tell me I didn't have my glasses.
Oh, you had a birthday? Did you come to our party? I think we invited you.
I know I had my glasses in my purse when I left home. Now I need them and they're gone. Oh, somebody took them out of my purse. I know somebody has stolen them.
I know it's upsetting to lose your glasses. I'll look into the situation. Why don't we go over to the discussion group? I know you enjoy it when Mrs. Jones leads the group.
They're going away. Yes. Well, we could keep talking.
That. Look what it says there.
You can't keep me here. This is a free country. You can't keep me here in jail. I never hurt anyone. Let me out. Where's my wife?
You're at the day center, Mr. Phillips. Your wife knows you're here. She understands, and she'll make sure everything's all right. Come on, we can play a game. Look, they're playing dominoes.
Let's start with the definition of hallucination. Hallucination is experiences of the senses that cannot be verified by anyone other than the person that is experiencing them. For example, the resident states that there are bugs in my bed. She brings her daughter in, pulls the covers back and says, "See, can't you see the bugs?" And the daughter sees nothing. Paranoia is the beliefs that are blaming and unreal. Oftentimes, the resident cannot separate facts from fiction. For example, this is when a resident accuses a staff person of stealing money from them, even when the staff person probably didn't work for a whole week. Delusions are beliefs that are opposite of the facts. The resident states to her husband of 50 years, "You're not my real husband." There can be several physical causes for hallucinations, paranoia, and delusions. Impaired senses, medications, especially combinations of medications, brain damage due to Alzheimer's disease, blow to the head, malnutrition or dehydration, a psychiatric illness. Physical illnesses such as infection or fever, or the possible physical illnesses that can reduce the amount of oxygen to the brain. Environmental causes such as an unfamiliar environment or an unrecognized environment. Unrecognized or unfamiliar caregiver, disruptions of routines. Ways to cope with hallucinations, paranoia, and delusions are many. Have the resident's hearing and vision tested. Have a medical examination to check for illness, infection, chronic pain, or bowel infections. A psychiatric evaluation for paranoia, hallucinations, and delusions to determine if medication might be helpful. Watch residents carefully to make sure that they're actually swallowing the medications that they're given. Check residents for bruises, scrapes from unwitnessed falls, and have the resident see a doctor if there's a significant change in the resident's level of alertness. The resident's environment should be changed as little as possible. For misplaced items, remind the resident where their valuables are and where they store them. Assist in looking for lost or misplaced items. Never scold the resident for losing or hiding items. Learn the resident's favorite hiding place and let other caregivers know where that is. Increase the lighting to reduce shadows. Do not directly disagree with a false idea by arguing with the resident. Respond to their feelings. Instead of telling the resident that their father is dead, try saying, I bet you really miss your father. Use familiar distractions to redirect the resident. Music, exercise, photo albums. Remember, the resident wakes up every day in an unfamiliar surrounding, having forgotten her environment and the trusted people in that environment. It is understandable that they are very suspicious. Hallucinations and false ideas may be harmless and are best ignored or accepted. If they do not upset the resident who's experiencing them, then there may be no reason to intervene. It is very important for the caregiver not to take these accusations personally and realize that the resident with dementia cannot control these behaviors. Incontinence can be very difficult for both the resident and the caregiver. The definition of incontinence is loss of bladder control. There are several physical causes for incontinence, such as infections. UTIs, or urinary tract infections, are very common in the elderly. Prostate problems for men, especially after surgery. Weak pelvic muscles for women can cause what we call stress incontinence, meaning the leaking of urine upon stress, coughing, sneezing. Chronic illnesses such as diabetes, Parkinson's disease, or strokes, or conditions that limit mobility or cause chronic pain can make it difficult to get to the bathroom. Vision changes can also make it difficult to see where the bathroom is. Inadequate fluid intake can cause bladder irritation. Dehydration may also decrease or eliminate the signal to urinate. The urge or the signal may no longer be understood by the resident. Medications, especially tranquilizers and antidepressants, can affect incontinence. There may be several environmental causes that affect incontinence. The distance to the bathroom might be too far for the resident, and poor lighting may make it difficult to find the bathroom. The bed may be too high off the floor and the resident can't get up. The floor and the toilet seat may be the same color, making it difficult for the resident to find it. Improper footing may make the resident afraid of falls. The resident might have trouble undressing and going to the toilet. Lack of privacy may make the resident feel embarrassed. Some other causes might be that the resident does not know what to do once they are in the bathroom. The task might be too complicated. The caregiver might not be giving clear and simple instructions. The caregiver may be rushing. The resident no longer able to express the need to use the bathroom. There are several ways to cope with this issue. Observe carefully and assess the problem. Have a medical examination to find out if there is an infection or other medical problems adding to the incontinence problem. If the resident has a fever for more than 24 hours, report it to the physician immediately. Urinary tract infections are often the cause of fever in the elderly. You should be aware that there are a number of medications that can treat incontinence. Be sure the resident is receiving adequate fluids throughout the day. And observe toileting patterns throughout the day and the night. Try to toilet the resident before their expected time. Toilet before and after meals and right before bedtime. Make sure the resident has actually urinated before getting off the toilet. When communicating with the resident, Make sure to use simple steps one at a time. Use short and simple words such as sit down. Watch for nonverbal cues that the resident has to use the bathroom. Things like reaching for the belt, pacing, tugging at the zipper, taking pants down, restless behavior, or an expressed facial expression. Make sure the staff knows the familiar terms for each of the resident for going to the bathroom. For example, potty, tinkle, take a leak. Listen carefully. The resident may say the wrong words. For example, I want tea or take a peek. Even residents with severe dementia care when they have an accident. Always be reassuring. And don't worry, things will be fine. Quietly praise the resident when he or she has been successful, and do not ever scold when they have an accident. Simplify clothing. Try Velcro instead of buttons and zippers. Try elastic waistbands for skirts and pants. Use underpants when possible. They can serve as a reminder to stay dry. Immediately change clothes when they are wet. Do not let the resident become used to being in wet clothing. Tennis shoes might be easier to keep clean if the resident is incontinent. Protective garments may become beneficial. Explore the variety of adult briefs available. Be sensitive and do not ever call these diapers or other names that would be degrading to the resident. After an accident, it is important that the resident's skin is kept clean to protect from rashes and open areas. Skincare products are available for incontinence. Signs on the bathroom door might be very helpful for residents that can read, and for residents that cannot read, try a picture of a toilet. When a resident has difficulty urinating, try giving them a glass of water while they're on the toilet. Let the water run in the sink, or put their hands in a dish of warm water. It may be also helpful to massage the resident's lower back. If the resident is incontinent at night, make sure that there are night lights on in the bedrooms, bathrooms, and hallways. Make sure there is no clutter in the way to the bathroom. Use rubberized or protective padding to protect the bedding. Staff should observe toilet patterns and develop a toileting schedule. They may need to gently awaken the resident every 3 or 4 hours and take them to the bathroom. Walk the resident to the bathroom and back. Tuck the resident into bed. It can have a very soothing effect on an agitated resident. If necessary, place a commode next to the bed. Several bathroom aids might also assist the resident in the bathroom. A raised toilet seat and grab bars can assist the resident in getting on and off of the toilet. Padded toilet seats might also be more comfortable if the resident has to spend time on the toilet for an extended period of time. Padded toilet seats might be more comfortable if the resident must sit for an extended period of time. Consider an intercom, a call light system, or a simple bell for those residents needing assistance. Other things you might want to keep in mind: you might want to purchase chair cushion covers that can be washed. Soiled clothing hidden in closets, behind doors, underneath the bed might be signs of incontinence. Check residents wearing briefs regularly. Make sure to put lids on containers that hold soiled pads and briefs. Respect the privacy and dignity of each resident. Losing control can be very embarrassing. Finally, if there are problems with constipation, and this is a new problem, make sure you're checking with the doctor. That could be a sign of several different illnesses. And make sure a resident has a high-fiber diet and receiving plenty of liquids throughout the day. Ask the doctor about stool softeners. Establish a routine to help keep track of the resident's bowel movements. And remember, the urge to go is often the strongest the first hour after breakfast. The problems that can be associated with bathing.
Hello, Bill. How are you feeling today?
I lost my book. Don't know what happened. Need to put it there.
Well, it's time. It's time for your bath now. Come on, let's go.
Oh, no.
Oh, come on, Bill. You've got a doctor's appointment. We got to take your bath now.
No. Looking for a book.
Okay. I'll just go do some other things while you look. Hi, Bill. I'm Mary. How are you feeling now?
Okay. Looking.
Well, I need you to help me look for my towel. Let's let's look for my towel on the sofa, all right? No, no towel there, no towel there. All right, let's look for my towel over here. Oh, there's my towel. Thank you, Bill. Thanks. Now let's go put this towel away, all right? Just this way.
Welcome back. Let's talk about taking a bath. Have you ever asked yourself, why is this bath such a problem with this resident? I did everything I was supposed to do. Well, many of us had. Let's look again. What could be going wrong physically or going on physically with the resident that would cause her to act out during a bath? Maybe it's depression. Maybe that resident could care less about what she looks like. Maybe it's pain and it hurts her to bend down and get into a bathtub or to get out of the bathtub. Maybe it could be loud noise of the water running into the tub, or the resident doesn't recognize hot from cold water. What role might the environment play? Poor lighting, fear of entering the tub or the shower because they can't determine what it is, lack of privacy. Maybe you need to let this resident keep her t-shirt on while she's in the tub or in the shower so she feels protective. It's important to consider if you should even wash the resident's hair in the shower. Also, start when you're washing from the feet up. Hot water is cold water before it gets from the head to the feet. A handheld shower is very convenient for us, but imagine what the resident thinks when he looks up at you and you have your hand up and you're coming at them. They may be frightened of the water or the force of the water as it comes out of the shower, or may be frightened that you're attempting to hit them, and they will, in protection of themselves, try to strike out, and understandably so. It's important that you have everything you need with you before you start that shower or bath. You don't want to let the resident be in the shower alone while you go out and get what you need. They may get out and refuse to get back in, or they may injure themselves in a fall. If the room is too cold, you've lost before you've begun. How can we solve some of these problems and eliminate some of the acting out behaviors that we see at bath time? Upon admission, when you're doing your pre-admission assessment, ask the family, what time of day did your mother take her bath? What day of the week did she take her bath? Years ago, many folks didn't take as many baths as we do now. Make sure, again, that you have everything that you need. Be sure the room is warm. Be sure that the resident has their privacy. Let them see you lock the door if that's important for him or her. Again, is the water temperature correct? If the resident refuses their bath, can you come back 10 minutes later? Can you give them simple choices, now or later? If the resident is fearful of a shower, but wants you to get in and be closer, can you put your rubber boots on and just step into the shower? Again, one step at a time for them. The residents, don't wash the resident's hair in the shower. Shower and baths are very complicated and potentially frightened experiences done alone. Doing them together often makes it more difficult for the resident to tolerate. Don't leave the resident alone if you need help. Pull the emergency call bell. Or if your facility isn't equipped with one, take a handheld bell in with you so that in the event of an emergency, you can ring that bell to call staff for assistance. Give the residents something to hold on to in their hands while you're completing the shower routine or bath. Maybe a big sponge is helpful. Allow the resident to wash as much of their own body as possible. Remember, the loss of independence and privacy is very difficult for the resident to bear, no matter how confused that they might be. Now, I've assisted the resident with his bath. How will you go about assisting him with his dressing routine?
Good morning, Mr. Phillips.
Hello?
My name is Janet. I'm your aide. How are you feeling today?
All right, I guess.
Good. It's a beautiful day today. bright and sunny. It's time to get dressed. Let's see. Would you like to wear the blue slacks or the brown slacks? Fine. Oh, and this shirt will look good with these slacks.
After Mr. Phillips' clothes are laid out in the order that they're to be put on, Janet helps him dress.
Okay. Now, Mr. Phillips, I want you to button your top button right here. Okay. All right, now try this button.
Janet helped Mr. Phillips each step of the way, and yet let him do as much for himself as possible.
Good, good. Now this.
Dressing can be a problem for many residents. Some of the physical causes may be depression, physical illnesses, impaired vision, changes in large motor skills. For example, they may be unsteady or have problems walking. Changes in fine motor skills. They may have trouble fastening buttons or zipping zippers. They may have memory loss or a side effect of medication. Some environmental causes may be poor lighting, too many distractions such as noise, clutter, too many people around, or the lack of privacy. Maybe the room is too cold. Remember, there can be several causes. The task may be too complicated. The instructions might not be clear. A resident may no longer be able to decide what to wear and no longer understands how to get dressed. The resident's attention span might be too short for the task. There may be fatigue or fear or anxiety. They may feel embarrassed about having to be helped to get dressed. They may not be able to accomplish the task. Make sure that the dressing problem is not a reaction to medication or a side effect. Have vision or eyeglasses checked. Check for depression. If a resident is depressed, maybe they truly don't want to get dressed. Show the resident the shirt that they are going to wear and introduce the idea of getting dressed. Keep the morning routines as familiar as possible. Avoid delays and interruptions. Make sure the room is warm enough, has adequate lighting. Close the doors and the blinds for privacy. Choose an agreeable area for dressing and use that same area every day. Encourage the resident to make decisions, but make those clothing choices simple. For example, do you want to wear the red dress or do you want to wear the green dress? When choosing clothing, choose clothes that are washable and do not need to be ironed. Choose clothes that fit comfortably. Zippers, buttons, and other fasteners might be replaced with Velcro. Make sure that the footwear is safe with non-skid soles, and make sure that the pants and the robes aren't too long. Try cardigans and button-down tops versus pullover tops. For men, try using suspenders or elastic waistbands. Tube socks are easier to put on because they do not have heels. For women, loose-fitting underpants, and avoid using a slip unless the resident feels that they are uncomfortable without it. Jogging suits are fairly easy to get on and off. Break down the task for the resident with dementia. Dressing can be very complicated. There are many steps involved. The goal is to help the resident do as much for themselves without becoming agitated. Some residents do many steps independently or with some verbal cues, while others will find it difficult to follow one simple step. Make sure you're doing one step at a time. Try these communication methods. Speak calmly and friendly. Use short, simple words. Give simple cues if necessary. Give praise and encouragement as the resident completes each step. Be careful not to talk down to the resident or talk to them like children. Be flexible and modify steps if necessary. A generation ago, people did not change their clothing nearly as much as we do. Make sure that you do not impose our values on others. Being reminded to change their clothing can be embarrassing, and it is very important to be sensitive to this. Getting dressed is a very private and personal activity. Many residents have never completely undressed in front of someone else before. Also, when a resident needs assistance with dressing, it conveys the message that they have lost this ability to do it themselves. This loss of independence for the dementia resident can be very difficult. It is important to remember that these feelings may contribute to some of the residents' resistance in getting dressed. Some residents with dementia tend to undress themselves frequently. This can be both embarrassing and inconvenient. But it is important to remember that they no longer understand what is appropriate. If this occurs, evaluate the situation. Is the resident dressed too warmly? Do they need to use the bathroom? Are they tired and trying to get ready for bed? Are they bored? Are the clothes that they're wearing too tight or uncomfortable? Some residents will develop a habit of putting layers of clothing on, regardless of the weather. In this situation, is the resident cold? Is there a reason why the resident should not be wearing the extra layers of clothing? Or is it because it bothers the caregiver? Try moving clothes that are often put on and substitute more appropriate items. Patiently remove the extra clothing, but knowing that you might have to do it several times throughout the day. Sometimes residents with dementia want to continue wearing the same outfit day after day, and they refuse to wear anything else. Do not argue with the resident. The family might possibly choose to buy several of that same outfit that the resident likes, or if not, that outfit could be laundered every evening.
The next category we're going to talk about is problems with eating and good nutrition.
Before you try to change the behavior or intervene, ask yourself, what makes this behavior a problem?
Have you ever had a resident sitting down and ready to eat, and you've put in front of them what you think is a very appetizing and attractive plate of food, and he doesn't eat? And when you attempt to redirect him to the food, he still refuses. What could be wrong, you're asking yourself? Well, if we look back at the 4 categories again, what could be going on with the resident physically? An easy way to answer that question is to put yourself in the resident's place. You've just gotten up, you're dressed, and you're going to brush your teeth after breakfast. You sit down at the kitchen table, and in front of you is toast, a cup of juice, and scrambled eggs. Now think about it. Your mouth is dry, like cotton. Your teeth feel like they have tiny little sweaters on them. What would you taste as you put a dry piece of toast in your mouth? Would you want to eat it? Probably not, because the taste of the toast will have the same taste as the taste of the inside of your mouth. And you could possibly choke on the toast if you tried to swallow it. How do we correct this? By brushing the teeth before breakfast, by giving liquids before solids, to wet your whistle, so to speak. Overall, when you're looking for a possible cause in the change of behavior, remember, dementia is a slow, progressive disease process. If the resident has drastic changes in his behavior from one day to the next, or one day over several days, it's usually the result of an unmet physical need or a change in the resident's physical condition. Let me share an example with you. We had a resident who was independent with eating. She was the first resident that got to the dining room table at all meals, and she was the last one to leave. And even in her confusion, mealtime was a very positive time for her. One Monday morning, we had to direct her to the dining room table. We served her breakfast, and she just looked at it, and she stirred it around a little, but she didn't eat it. We took her temperature, we took her blood pressure, we checked her record to see what it was the last time it had been taken, we checked her bowel movement sheet to see if maybe that was probably the cause, and we also looked into her mouth. And everything checked out fine. But she didn't eat lunch either, and she clamped her mouth shut when we tried to assist her with her supper. Well, we thought this might be another phase in the disease process, another loss that she has as a result of the dementia. But we had one more thing that we wanted to try. This resident loved ice cream, so we gave her a large bowl of ice cream. And she had a big smile on her face, and she put that large spoonful of ice cream in her mouth, and then she started to hold her face and moan. The problem was that she had what appeared to be a deep hole in one of her remaining teeth. And it was very red by that time around the gum line, causing her much pain. And it gave us and it showed by the change of her behavior, her refusal to eat, her inability to be her usual happy, cheerful self. What that incident did was to remind us that we need to look just a little bit harder. What could be going on physically to change the resident's behavior? Let's look at some other possibilities. Vision can affect a person's desire to eat. Do their glasses fit? Do they need glasses? Are their glasses clean? Don't be offended, but take a look at your residents. Check their glasses. You might be surprised at how many folks wear dirty glasses every day. What good are hearing aids if they stay in the dresser drawer all day, or if they're in but not turned on? Hearing loss can also be the result of wax buildup in the ear. You'll want to check with the resident's family. Does he have a history of this problem? And if so, you'll want to send him to the physician. A few other causes of loss of appetite might include chronic pain, maybe the arthritis pain. It can cause significant changes in behavior as well. Again, as I mentioned, constipation, depression, acute illnesses. Changes in the appetite or changes in the taste of food is often related to the medications that the resident is receiving. As the resident with dementia progresses in the disease process, he may lose the ability to recognize eating utensils and know what they're for. He again may have already lost the ability to recognize the sensation of hunger. You have to be the detective. You have to be the one that watch for behavior that might indicate that he's hungry. Now, what role does the environment play in terms of how it might affect the resident's appetite? Of course, it's a new home. The resident is going to feel lost, uncertain, or confused. Remember what I said earlier about residential character. The dining room should look like a dining room with flowers and tablecloths and pictures or placemats. It should smell like a dining room. It should be close enough to the kitchen that the odor of food will fill the room at mealtime. It should sound like a dining room with conversation. Remember, poor lighting or too much clutter, too much noise, or too many people in a small dining room can increase the resident's agitation and result in his inability or unwillingness to eat. The conversation at mealtime should be resident to resident or caregiver to resident. Never caregiver to caregiver talking about what they did the night before. Maybe you'll need to serve finger foods, Jell-O jigglers, mashed potato sandwiches, French fries, fresh fruit and vegetables, bowls rather than plates, bright placemats, maybe a damp washcloth under the plate to prevent the plate from slipping away as the resident is trying to eat. Check with an agency that provides devices that would make it easier for the resident to continue to feed himself, maybe large handled spoons or a nose cup with the bridge of the nose area cut out of the cup so that the resident isn't hitting his nose every time he's trying to take a drink. Remember, if you're feeling rushed, the resident will sense that and become frustrated and fearful and anxious. And the end result of that is his inability or refusal to eat or allow you to assist. If you're assisting the resident to eat who has problems with swallowing, you might want to remind him each time, chew, chew, swallow. Check the mouth periodically for stored food. Maybe offer him smaller bites. Allow plenty of time in between mouthfuls of food. Also, dipping the food into liquids might help ease the swallowing process. Or put a bite of food on his lips or mouth for stimulus. Or first take a portion of the main course if you're having, let's say, mashed potatoes and gravy, and then the second spoonful might be something sweet, and alternate with the two. Also, try taking small portions of the main food and then dip them into the sweetened food so that the sweetened food touches his lips first, and that might induce him to open his mouth and take more food. For choking problems, first and foremost, you'll want to alert the physician. Under his direction, you might want to try thicker liquids. You'll keep liquids at room temperature whenever possible. You'll try soft cooked foods, scrambled eggs, cottage cheese, mashed potatoes, applesauce, and nutritional supplements. You will always want to keep the physician alerted. For a resident who appears hungry all the time and is frantically looking for something, you might want to offer 5 or 6 small meals of the day. Or you might want to offer walking around food. For problems with people undereating, you might want to offer a small glass of juice before a meal. Or you would offer maybe a small glass of wine, depending on if the medication allows for that and the physician allows for it. You might want to offer in-between meal snacks. You never want to give them a can of Ensure along with their meal, because in drinking the Ensure, they're not going to eat the rest of the meal because they're going to be too full. So you want to offer those between meals. Be sure that your residents are getting enough exercise to stimulate their appetite. Talk with the family. What was their favorite food? What was their favorite bedtime snack? We have a resident that eats popcorn and milk and has every night for 20 years. No, he doesn't have a bowl of popcorn and a glass of milk. He has a bowl of popcorn with more milk poured on top, and he eats it with a spoon. And that is his bedtime snack. And after he's eaten that, all is well with the world, and he's ready to go to bed. We learned that on the admission assessment that pre-admission assessment that we completed. And I have to tell you that it helped us to alleviate many problems that could have arose. As you're assisting your resident to eat, you want to sit directly in front of them, especially if his vision is poor. Never stand to feed a resident. What are you telling him when you're standing? You're telling him you're in a hurry and they need to hurry. Sometimes it's helpful to tell a resident lunch is going to be ready in about a half an hour. They may not have a concept of what that half an hour is, but they do have an understanding, or usually do, that it will be in a short amount of time. We have dining room hostesses, residents that take the flowers off the table, take the runners off the table, and sometimes they even wear aprons to do this. And again, it helps give residential character. You would be surprised at how many of our elderly male residents who will come to the dining room because they see elderly ladies in aprons starting to set the table, and they smell the food cooking. Residential character. Again, we've accomplished several things by allowing the residents to help at mealtime. We've given them a feeling of self-worth. They feel good about themselves. They have a purpose in their day, and these are things that they may have done all of their life. As I said, we promote residential character, and it may jog another resident's memory. And if some of our residents require more help than what they're giving help, then we take the time to do that. It's up to us as the caregivers to be flexible and patient. Other ideas that might help to make mealtime more pleasant is to make sure that the resident is comfortable. Has he gone to the bathroom before lunch? Are his pants too tight, or his dress or her dress constricting her? 4 people at a table is a comfortable number. Again, talk with the family. What has been the resident's routine prior to coming to your facility? Tables with 10 to 12 people at them are for lumber camps, not for family settings. Again, talk to the family. If this resident is coming from home and they're used to the last 5 years eating by themselves in their own kitchen table, no one else around, or if they're coming from a nursing home and they are used to having their meals in their room as opposed to the dining room, you will want to gradually nurture them 1 meal a day or 1 meal a week, 2 meals a week, gradually gaining their trust and helping them to feel more comfortable and coming out to joining everyone. You will cause a drastic change in their behavior or great discomfort and distress to them if you expect them to be admitted at 2 o'clock and have supper with 15 other people at 5 o'clock. Another challenge when caring for people with dementia are sleep disturbances. Robin is now going to tell us why this might occur and give us some options to caring for residents with this difficulty.
Sleeping, or the inability to sleep, is a very common problem. Some physical issues affecting sleeping patterns could be illnesses such as congestive heart failure or pain caused by arthritis. Urinary tract infections can cause a constant pressure to urinate. Restless legs, often caused by metabolic problems, depression, side effects from medication, breathing difficulties, or sleep apnea. Look close at the environment. Is the room too hot or too cold? Does the poor lighting or dark room cause confusion? The resident can't find the bathroom, therefore they can't sleep. Is the total environment new to the resident? Other reasons for sleeping problems may be that they're already spending too much time in bed. They may be napping too much throughout the day. They might be too fatigued to calm down and go to sleep. They're not getting enough exercise to be tired out after the day is through. The resident could possibly be having hunger pangs and needs to have a snack before going to bed. Was there an upsetting experience prior to bedtime that agitated the resident? Maybe the resident had a bad dream. Make sure the resident has had a good medical workup to identify if there's any medical problems the staff should be aware of. Treat pain with medication at bedtime if the physician okays it. Also, discuss with the doctor remedies for the restless leg or any sleep apnea or breathing problems. Again, look for any side effects of the medication. Check the resident to see if they're too cold or too hot. Also check lighting. Shadows may keep the resident awake. Night lights help with safety and cut down on confusion in the dark. Make sure the bed and the room are familiar to the resident and the resident has used the bathroom prior to going to bed. By providing enough stimulation, activity, and exercise throughout the day, the resident should be tired out and ready for bed at night. Avoid any upsetting activities late in the day. Reassure the resident that they are safe and it is dark out and it is time for sleep. For residents that sundown, that is, that are agitated and wander more in the late afternoon, try to distract them. Use music, an activity, or go for a walk. Turn lots of lights on, brighten the atmosphere. Try to minimize noise, confusion, and the number of people around during that time of day. Try a rocking chair, they're very soothing. Increase staffing or family visits. Provide more one-to-one attention for that resident. Be aware that shift changes are noisy and can be very confusing. Specific medications may take the edge off of agitation. Use sleeping medications only as a last resort. Be cautious with sleeping medications. They may cause increased confusion and unsteadiness. Problems with sleeping or late evening agitation are often a stage of dementia that passes very quickly. It is important that you recognize these things in the environment that could be contributing to the sleep problem. A log in a diary can be helpful to you to identify these problems.
Wandering.
Where are you going, Mrs. Bennett?
Stay away from me. Where are we going?
To the day center. Oh, hi, Mrs. Bennett. It is a nice day, isn't it?
Where are we going?
Oh, we're going back to the day center. It's safe there.
Wandering. I can imagine that most of you, if not all of you, have had a resident that is frequently attempting to leave your facility without supervision. And how many times have you said to yourself, if Mr. Jones goes out the door one more time, I don't know what I'm going to do? Well, we've all had thoughts like that, especially when we think that we've done everything possible that we need to do, and the resident should be content to stay inside. Well, I have a few more ideas for you. Remember, wandering behavior could be the result of physical changes that are taking place in the brain, and the resident has no control over it. You might want to offer this resident a snack, again because he's lost the ability to recognize that he's hungry, and he's looking for something, but he doesn't know what it is. You might want to check what medication he's on. Could this restless wandering be the result of medications, one interacting with another? Is this resident in pain? One resident who went to adult daycare had drastic changes in his behavior. He went from being pleasantly confused to being aggressive and attempting to leave the adult daycare setting. And on the second day of this behavior, of this drastic change in behavior, he attempted to strike out as a staff person as she tried to redirect him and bring him back into the facility. When I was called to consult, I was stumped as well. When all else failed, we called his family. And we asked his wife, what had they done over the weekend? Did anything unusual happen? And she said, no, my daughter came from Chicago and she brought Dad some new shirts, and he has one on today, doesn't he look nice? And she also brought him a new pair of shoes. And then the light bulb went on. You see, as a routine in adult daycare, they don't often take off the residents' shoes and socks. And when we did get Carl to take off his shoes, his feet were very red and tender, especially around his bunions. Carl was in pain. His feet hurt. His shoes were too tight. He couldn't tell us that. The only thing he could do was show us by a change in his behavior. And what looked like him trying to wander and get away was really him trying to get away from the pain. And he didn't know how to, and he didn't know where it was coming from because he couldn't recognize it as pain. Sometimes residents having the need to go to the bathroom may want to get outside because back in their remote memory, they may be thinking about an outhouse, and an outhouse is outside. So having to go to the bathroom is often a good indicator when a resident is attempting to wander. What might be going on in the environment that would promote a resident to wander? Is it too hot? Is it too cold? Residents who are cold are frequently agitated and aggressive. Is there too much stimulation? Too much noise and clutter? Are the general goings-on making him very agitated? And he just has to get away. Is there nothing going on? Is everyone asleep in recliners around the room? Is the staff just talking to each other and not talking to the resident? What was the resident's past life? What were his interests and his hobbies? This is where your pre-admission assessment is very important. Is this resident searching for one familiar person or family member that he knows is just outside that door and he just has to get to them? As we talked about earlier, does the resident watch the exit door and want to go home just as well? Does the resident's past history include him working on the 311 shift, and now because of the dementia he is reliving his past or living in the past, so he wants to go to work at 2:30 in the afternoon? Is his biological clock, his internal clock, telling him it's time to get up and go to work? Is your environment, the staff, and other residents too tense and he senses it and he wants to get away because he feels fearful of the unknown? Are you attempting to help the resident to complete a task and it's too complicated and he walks away? Does he walk away from an activity because it's too childlike, or because he's frustrated, or because others can complete the task or the activity and he's not able to, and you've not adjusted that activity to what his abilities are? Is the resident being overwhelmed by conversation? or overwhelmed by reacting to other residents and other staffs. These all could be things that could cause a resident to wander. And what can be done? How do we intervene or redirect him? How can we problem solve? First of all, good rule of thumb, if it's not broken, don't fix it. If the resident is wandering or pacing and his environment is safe and he's not putting himself or anyone else at risk, let him walk. Remember, you can change the environment, and by doing that, you can have an effect on his behavior. Decrease the noise level, as I mentioned before. He can no longer tune it all out. Can you go for a walk outside with him? Look around. Are his boots and his hat and his coat in his room? These are very strong visual cues that it's time to leave. Is there a household activity that he can do during these periods of time that he's restless so that he can feel useful? Our dining room hostesses, one of them sweeps the floor after every meal. Why do we let her do that? Well, she's a wanderer after meal times. She's very quickly up and ready to go out the door. And upon investigation, and all that investigation took was a conversation with her, we found out that she thinks that the dining room is a restaurant. And what do you do when you're done eating at a restaurant? You get up and you leave and you go home. Now we distract her by having her help us clean up. And her desire to always be a help and always be a gracious hostess usually lasts over the period of time where she might want to leave the facility. Of course, this kind of problem solving or information must be noted on your individualized service plan. And why she does the cleaning up must be noted that she desires to. And it's not because we want her to do it so that we don't have to pay the staff to do it. How strong is your activity program? Again, part of the information that you will gather during your pre-admission assessment should include past interests, hobbies, and skills. Many of our residents' past interests have had to be adapted to meet what their abilities are now. We have an avid fisherman who truly enjoyed sanding fishing lures. Well, we had another member of another family cut out small fish, and this gentleman continues to sand those fishing lures, continues that same hobby that he had enjoyed in the past. We just made changes in it so that he would be able to complete it and complete it successfully. You might want to reconsider some of these communications approaches as well. Reassure the resident often about where he is, always speaking in a calm and normal tone of voice. Sometimes the resident doesn't recognize the words you're saying, but he recognizes the tone of voice that you're using. Sometimes written assurance can help if the resident is in an earlier stage of confusion. If the resident is mildly confused, a note saying to her, "Your daughter will be here at 2 p.m. might be helpful. Again, be sure that her daughter will indeed be there at 2 p.m. and that you're not giving her false information. If the resident is agitated, don't try to reason with her. Don't argue. Remember that the resident truly believes that she's correct, and if you're trying to tell her that she's not, you're the liar, and she will be assertive and aggressive with you. Never stop the person that is wandering by coming up behind him and grabbing his arm from the back and saying, "Stop, don't go out there." How would you feel if you were lost in a strange place, frightened, and trying to find your way, and someone comes up behind you from the back and yells, "Stop"? Would you resist? Would you try to protect yourself? Of course you would. And why wouldn't the person with dementia do the same thing? If the resident is a nighttime wanderer, keep some of the lights on. Offer him a snack, a warm snack. We keep individual packages of warm oatmeal available for residents that get up during the night and are hungry. It's warm, it's sweet, and it sticks with them. If he's in pain, watch for facial grimaces or guarding. If you're touching in any part of his body and he reacts, that's guarding. You know that he has discomfort. If he's squinting, or if his hands are clenched and tight, or if his arms are tight against his body. Take a look at what time this resident went to bed. As we age, we need less sleep. If the resident goes to bed at 6 p.m., which is nice for the p.m. shift, why wouldn't he be ready to get up at 2 a.m. after he's had 8 full hours of sleep? He doesn't need much more sleep after that. So he's up at 3 in the morning, and the night shift is frantic to get him back to bed because they have so much that they need to do. What are we going to do? We're going to offer him food. We're going to assist him to the bathroom. We're going to offer him a recliner to sit in. We're going to give him a blanket to cover up in. We're not going to rush him to get back to bed. We're going to go one step at a time. If he rests in that chair for an hour or two, what's the problem? He is sleeping. If you're having difficulty with keeping track of the wandering resident at night, you might try what we tried with great success. Put a strip of Velcro on each side of the doorway. Put a felt banner with Velcro on each end of the felt banner and attach it to each side of the door so it goes across the room. Sew some bells across the bottom of the banner so that when the resident walks through the banner, and he will be able to because the Velcro will give away with just a little bit of pressure, you'll hear the tingling of the bells and you'll know that he is out of his room. It's not a restraint because you are not restricting the resident's movement and you are not restricting him to stay in his room because all he has to do is walk out and walk through that banner. If you have nighttime wanderers and part of your responsibility during the night is to do some of the meal preparation, remember, lock everything up if you leave the kitchen. Lock up the knives and the scissors, meat forks, anything that person might be able to walk in and pick up and either fall and hurt himself. A gated courtyard with walking paths, benches, flowers, something of interest that will catch the resident's attention before he walks on is very helpful for wandering. We have in our courtyards what we call attention spots. Flower gardens, apple trees, a large bench under a big shade tree, clotheslines with clothespins on, vegetable garden, flower gardens. The resident can stop, take a look, ponder, and move on a few feet or to the next attention spot. So the residents are allowed to spend time outside safely and securely, weather permitting. Of course, we have to monitor them whenever they do go outside. But nothing is fail-proof. So our residents who are at a risk to wander or leave the facility without supervision wear a safe return bracelet from the National Alzheimer's Association with their national number on it as well as our facility's phone number. And we keep a current photo on hand in the event of this type of an emergency. Each resident who is at risk to wander is specifically identified in their individual service plan as well as approaches and interventions so that our staff understands of what to do in this event. Keeping in mind your other options, again, you might want to put signs up that say to the bathroom or to the dining room. You want to give them visual cues so they understand within their own environment as best they can where they want to go or where they can go. Another solution that works for earlier stage people that are confused would be a large red stop sign that says stop so they don't go through a door. Or sometimes a sign that says no might be helpful for them. Or a full-length mirror at the end of a hallway so that the resident, if he's walking down that hallway, he sees someone coming directly at him. He may not recognize himself, and he will often turn around and go back the other way. Or he may stop and talk to that person that he sees in the mirror. or he won't recognize that person and become agitated. Again, that's why it's vitally important that you know each of your residents and you know what works and what doesn't work. A good idea is to keep a log. Write down the time of day that the resident attempts to wander. What is he doing prior to? Who's around during that time of day? Who are the other residents? Who are the caregivers when you notice the most frequent attempts to leave the facility? If the resident wanders or attempts to leave at the same time every day, especially during nighttime wandering, has he worked during the night shift again? We learned this the hard way because we had a resident who was a baker, and he was up at 3 a.m. every day to start his day because he needed to get to the bakery. What we did was change this resident, our routine, to match the resident's routine. His day started at 3 a.m. He got his partial bath, he got dressed, he had his breakfast, he had his newspaper, and then he sat in the recliner and he went back to sleep. But as far as he was concerned, he had started his day and he was getting ready to work. He then oftentimes would go back to bed and get up then again at 8 and have his second breakfast. But that's what worked for him. When residents come to your CBRF, we cannot expect them to fit into our schedule, our time, our routine. We as caregivers need to adjust to them. Remember, this move is difficult enough, and it's our responsibility as caregivers to ease this transition as best as we can. Repetitive actions, repetitive actions, repetitive actions. Guess what Robin is going to talk about next? You're right, repetitive actions.
Yes, Rose, I'm going to talk about repetitive actions. Repetitive actions can be caused by the effects of medication, especially repetitive motion. Physical changes in the brain due to dementia and memory loss can cause repetitive actions as well. In the resident's environment, they may not understand the sights or the sounds, and this can cause anxiety. Being separated from loved ones can cause repetitive questions like, "Where is my son?" Other causes might be misunderstanding of what is happening. You may hear questions like, "What are you doing? What are you doing?" The inability to express needs such as hunger, needing to use the bathroom, or they may be trying to express an emotion such as fear. There are several ways to cope with or handle repetitive actions. A medical examination will identify any illness or pain, and the medications can be reviewed. Distract the resident with a favorite activity or food. Try these communication methods. Respond to the emotion instead of the specific question. The resident might just need a little bit of reassurance. Remind with brief and simple statements. Do not remind the resident that they have asked that question before. Try a gentle touch, a hug, or a shoulder rub. That might be more assuring than words. Use a calm voice when responding to repeated questions. You may choose to use simple written reminders for those residents that can still read. Do not discuss plans with the resident until just prior to the event if this causes agitation and repeated questions. Ignore the behavior or the question. If there is no response, the behavior may stop. Use memory aids, signs, large number clocks, calendars, and schedules. This will help orientate the resident. Remove things in the environment that may trigger repetitive questions. Coat racks often do this. They want to know when they're leaving. When are we going? When are we going? For repetitive motions such as moving the tongue in and out or rubbing hands together, tapping legs, try having the physician or the pharmacist review the medications. Occupy residents' hands with an activity or an object. Try distracting with food or music. Keep these points in mind when resident is stuck on one step of a task, repeating it again and again. Use touch and pointing to gently move on to the next step. Be aware that interrupting the movement may be very annoying to the resident and cause further agitation. Be sure to allow enough time so the resident is not rushed through the task. Repetitive motions can be necessary before the resident can move on to the next step. You may want to keep a log or a diary to help determine, if possible, what is causing the repetitive actions. Remember yourself that residents with dementia do not have the ability to remember because of the changes in their brain. Sometimes residents with dementia have lost the ability to know how to get attention and may be using the questions as an attention-getting device. Repetitive motions with the tongue in the mouth are sometimes indications that the resident is getting too much medication and the physician should be notified. Occasionally, when the resident asks the same question over and over, it's because they're fearful or they're anxious about something. Responding to their emotion calms them. Repetitive motions and questions can be one of the most upsetting behaviors for caregivers. Sometimes the caregiver needs to remove themselves from the area and take time out for themselves. Remember, caregivers always need to take care of themselves. Screaming and verbal noises can be very difficult behavior.
Good morning, everyone. Dave, Betty. Today I thought we would discuss friendship and talk about some of the friends that we've had in the past.
I had a friend, a very special friend. He moved away.
Leave me alone! Get out of here! I'll kill you! Don't come near me!
Mrs. Witz, it's all right. I'm here with you.
Leave me alone! I'll kill you! John, I'll kill him!
John's fine. He takes good care of you.
I hate him! I'll kill him!
Doris.
Hello.
Widow.
Oh, you look so happy. I'm glad to see you feeling so good.
Widow.
Oh.
Widow.
I can't. I have to see Bob now. See you later.
Widow.
Bye.
The behavior may be screaming, repetition of unrecognizable words, verbal noises, talking that is disorientated, moaning, or whistling. Some physical concerns may be causing these behaviors. Is the resident hungry? Has the resident been incontinent, or do they need to use the bathroom? Are they fatigued or need assistance changing positions? Vision and hearing loss can cause a resident to misinterpret the environment. Impaired ability to speak or to be understood. The resident may have severe medical problems that cause them pain or discomfort. The environment could be too noisy. There could be too much going on in the environment for that resident to handle. If the resident is physically restrained, the resident may be upset by another resident's behavior. Another reason that the resident might yell out is if they're having something done to them that they don't understand. Things like a dressing change or an enema. Bathing, dressing, and mouth care may cause verbal behaviors. Fear and anxiety, frustration can also cause these behaviors. Some residents are just bored and lack stimulation. Others just seek attention. In order to cope with these behaviors, a medical examination is always a good idea. Check for illness, pain, infections, impactions, or other causes of discomfort. Provide the resident with adequate meals and snacks to minimize hunger. Have a regular toileting schedule to reduce incontinence. Rest periods can minimize fatigue. Check hearing aids and batteries regularly. Also check eyeglasses. Lower stress in the resident by creating a more relaxing atmosphere. Minimize noise and stimulation. Use relaxation methods to minimize fear and anxiety. Gently touch residents' hands and arms. Try communicating with the resident in a soothing voice and identify them by name. Explain things in clear, simple sentences. Always break tasks into short steps. It is helpful for staff to use regular routines for bathing, dressing, getting up, and going to bed. Mealtime as well. Identify staff that work well with individual residents and try to be consistent. Plan a time to talk with the resident, a few minutes while helping them with activities of daily living. Always encourage participation in meaningful activities to minimize boredom and frustration. Softly read to the resident. Medication should be used only as a last resort. Verbal behaviors are usually seen in the later stages of dementia. Many residents who shout, cry out, are physically unable to move and are wheelchair or bedbound. This is not always the case, however. The underlying problem is the resident's inability to communicate their needs, wishes, and thoughts. This concludes my portion of the video, Wanting to Go Home.
I want to go home. My mother's waiting for me. I want to go home. My mother's waiting for me. I want to go home.
You'll go home soon, Mr. Jones. Come and sit down, and we'll look at this magazine together.
My mother's waiting for me.
I know you're worried about your family and getting home. I'll make sure you get home. Come and sit down and wait a while.
Welcome back. Now we're going to talk about wanting to go home. You know that wanting to go home is a pretty typical feeling, especially if you've been far away from home or lonesome or feeling lost. You know that in understanding this, you'll have a small idea of what the person with dementia feels. This resident, again, may be living back in their past, in their remote memory, 50 years ago. He may think of home as a farm in the country, or a small apartment in the city, or one of many houses in a big suburb, or it may be in the country. This resident, no matter the place, wants to get there. Again, these feelings are because of the physical changes that are taking place in the brain. What role does the environment play? Well, because it's new, because it's a change of setting for him. Maybe your environment, the furniture and the kind of decorations that you have, is something that that resident doesn't recognize. Maybe it's too new, maybe it's too modern. We often get tempted to make everything mauve or blue because we have a sense that that helps to calm the resident. But keep in mind, what were the colors that they were comfortable with and that they lived within all of their lives? Do all the rooms look the same? Do none of them have residential character? Nothing to send the message to the resident where he is? What can you do to help the resident who is wandering? What can you do to problem solve? Can you take him for a walk? Can you sit down on the front porch and visit for a few minutes? Can you reassure the resident? Let them know that you're there to help, that they're not alone. Again, keep track. What upsets the resident? What is he doing before he wants to wander, before he wants to go home? Oftentimes, if a resident is able to talk to his wife on the phone, her telling him that she can't come anymore tonight, for whatever reason it might be, if she's no longer able to drive at night or if it's too late, and allowing him to visit with her on the phone might help him to feel safer and content to stay. Sometimes it takes more than one call to help that resident feel content. What we do is actually rehearse with the family member what they need to say and how they need to say it, so that we don't end up with a family member alone at home and very distressed and feeling guilty that they've left their husband there. In doing this, we're helping them to understand the disease process or understand dementia, and we're also allowing them to play a very important role in his care, and that's helpful to them. In one situation, we had a family member that we made a video of, and whenever the resident was particularly insistent on getting home, we turned the video on for him, and he would sit down and his wife would read him the newspaper, and she would be holding the paper in the video, and he would be content and sit there and read the paper. One newspaper, didn't update it every day with the new news, all positive news and the kinds of things that he liked to hear about. And that almost always worked for him. Remember, if you're trying to redirect that person who wants to get home, you want to do it one step at a time. Offer a snack or an activity. Just don't say, Mr. Johns, here's a magazine, sit down, you can look at it, and then walk away. Because what have you given him? He'll put that magazine down as well and walk right behind you or out the door. We have a rule, and that is spend 10 to save 20. Sit down with that resident and spend 10 minutes of one-on-one time with him. And we all have, if we can adjust our days and know how to adjust our workload, that 10 minutes to spend with that resident. It will oftentimes save 20 minutes in the future as you're out the door and down the sidewalk attempting to bring that resident back. Keep his coat out of sight. Again, coat and hat are strong visual cues to him that it's time to leave. It's time to go home. I'd like now to talk about some individual treatment approaches and how we can incorporate them into our everyday routine. First of all, I'd like to talk about the rescue approach, to save the resident from whatever he or she feels is threatening or a harmful situation. To take something negative and turn it into something positive. A bath, toileting, trying to exit the facility, maybe an altercation or an argument between one resident and another resident. The rescue approach calls for one caregiver to be the good guy and the other caregiver to be the bad guy, so to speak. The other caregiver is the one that's the bad guy that's going to take the responsibility for the resident's negative reaction. The good guy is the one that's going to, the caregiver that's going to set up a positive approach. By this I mean, I might be trying to assist a resident with cleansing after she's been incontinent, and she resists. And the second caregiver, the good guy, comes in and says, what's happening here? Let me help, in a kind of a conspirator's tone of voice. I'll help you. The resident will almost always go with the good guy. They feel less threatened. They have a feeling of trust for that person who only has their best interests at heart and who's going to help them. I've shared this routine many times across the state. And in one time, a staff person came up to me and told me after a presentation that he had tried the rescue approach. He was the only caregiver on the PM shift on a 32-bed Alzheimer's wing. And he went in to assist a resident with his evening cares before bedtime. And as that resident began to become uncooperative and refused to allow him to continue his cares, the caregiver went out of the room. He came back in 10 minutes later and said, who was that other guy that was in here giving you such a hard time? And yes, it worked. The resident had really forgotten who that direct caregiver was. He just knew that someone was in there and someone had made him very angry, and he allowed the same caregiver that he didn't recognize to allow him to assist with care. Another individual treatment approach is solving a crisis one step at a time. When I still worked in the nursing home, we had a resident who wanted to go home. Rather than hurrying her back inside, we always walked outside with her for a little ways. Then we asked her to come inside so we could call her son. And when we got her inside, we offered her her favorite snack. And if after eating her favorite snack she still wanted to go home, we would offer to call her son. And he would tell her to spend the night. Or he would leave a tape-recorded message on his answering machine that said, Mother, I'm not home tonight. I won't be home till late tomorrow. Go ahead and stay at your other home until I get back. And that's what was all that she needed. If we would have skipped any one of those steps, if we would have followed her out the door and said, well, come on, Agnes, we need to go and call your son, we would have made things worse for her. She would not have developed that trust in us. She would not have allowed us to bring her back in. She would not have been willing to move on to the next step, one step at a time. We also practice IV therapy. individual validation. You know that if you're dehydrated and you go to the hospital, the first thing that your physician is going to do is put an IV in your arm so that you can have the fluids that your body needs. Well, IV therapy, individualized validation, is entering the resident's reality, wherever that reality is, and offering him immediate treatment or an approach. It's not psychotherapy. You're not looking for deep-seated emotional problems that causes his behavior. You're looking to make a connection to relieve that person of stress or fear as honorably and humanely as possible. Remember, it is because of the deterioration in the brain and the fact that maybe the only part of that resident's brain that is still functioning is their remote memory from 50 years ago. And that's the reality that you're finding yourself in. What you're having to work with is the resident's reality, wherever that reality might take him. So you need to enter their reality. And sometimes you're going to go on some very interesting journeys. Some examples that I'd like to share with you. One in particular was a resident who was a farmer. She was not just a farmer's wife. She was his partner. She worked with him in the fields. She worked with him in the barn. She did everything that she was able to do. And then the effects of irreversible dementia started to happen. And she was no longer able to maintain her farm or her home after her husband passed away. So she came to the facility. Very frequently in the evening, she would want to put on her barn clothes. And she would become very restless and agitated because she needed to put on her barn clothes because she had work to do. Her barn clothes included a scarf and a sweater. Well, one particular evening, we had another resident who had a lovely silk scarf on. And Annie wanted to put on her barn clothes. And she looked at the other resident and saw that she had a scarf on. And she almost strangled her trying to get that scarf off of her because she figured the other resident had her barn scarf on. Well, one of the staff persons talked to her and said, Annie, you live here now. You don't have to work on the farm anymore. You're not able to because you're 88 years old. Your son owns your farm now. He'll take care of everything. You don't have to worry. And how of an effect did that have on this resident? She became very upset, very angry, very frustrated. Why? Because the staff person had taken all of her dignity. She, in other words, said to her, you have no worth. You have no purpose here. We just take care of you. You don't have to do anything yourself. What we did when we investigated this incident is again call the family in and have them play an active role in problem solving. We explained to them that she needed barn clothes. And her son said, that's not a problem. I think her old sweater is still hanging in the barn that she always wore. And I know her scarf is. The family brought the sweater and the scarf from the barn. And whenever Annie got very frustrated or agitated and had to leave or had to put her barn clothes on, we took them out of the big tied plastic bag that we kept them in and up in the top of her closet, and she was able to put them on. And she wore her sweater and her scarf around the facility until she felt it was time for chores to be over. We entered her reality. We helped solve the problem. We gave her a sense of dignity and a sense of self-worth. And the family would always thereafter keep a sweater and a scarf in the barn so that when we needed a fresh, so to speak, sweater and scarf, because that the smell of the barn is very important to Annie, as was the sweater and scarf. In entering her reality, we solved that problem. Any way that you can provide immediate interaction and reassurance is helpful to your resident during a distressed state. Don't lie to them. You can't take them to their mother who they think is dying, but you can talk to them about their mother, letting the resident lead the journey, letting them set the pace. In this unit, we have covered the 4 basic causes that we see presenting challenging behaviors for our residents. The residents' physical and emotional health, the environment, tasks that are too complicated, and communication. Now I'd like to just add a few more things for you to think about. You will want to reassess the resident's behavior. Can it be a signal of an infection or a medical need that's not being met? You'll want to reconsider, is this behavior harmful to the resident or to others? And if it's not, can you adjust the behavior, or can you, more importantly, adjust your attitude to the behavior? If a resident is frequently packing their grip, and that's what they refer to oftentimes as their suitcases, packing to go home, and they're unpacking their closet and filling up their suitcase and unpacking their suitcase and filling up their closet, and their room is beginning to be a mess. But that resident is in there completely content and doing a purposeful activity, purposeful for them. You'll want to reconsider, whose problem is it? Is it yours or is it the resident's? You might want to rechannel the behavior. Some behaviors are thoughts that just get stuck in the person's brain, and he may stubbornly resist giving them up. They could be allowed to continue the behavior, maybe in just a less disruptive way. We had a resident who liked to rummage. She liked to go through everyone's things. Now we've given her a box with handles on, full of stuff, and she's always rummaging through her stuff. Same behavior, just not as disruptive, not going into someone else's. Another resident was a shopper. She shopped in everyone else's room, and that's where the problem was. She loved to shop. We actually made a rack and got from the penny store the size discs and put them on the rack. And now this resident continues to shop in her own room. And she has sizes 8, 12, 14, and 16 to pick from. And they're her own clothes, but they're just rearranged. Same behavior, but we just rechanneled it. Can you redirect the resident? Sometimes a snack, a walk, helping you with a project, sweeping the floor, letting the resident feel useful. Always reassure the resident. A person who's unable to make sense of where she is, or often who she is, needs constant, loving, gentle reassuring. Just knowing that you understand her fear is oftentimes enough to give her that sense of safety. Knowing that you care about her and that you won't abandon her is a powerful, reassuring message, and almost always has that calming effect. If you take the responsibility of controlling what you can, then the residents that you're caring for can only benefit from your caregiving. You would be the specialist. This completes our unit on challenging behaviors. We will conclude the unit by taking the post-test. Please remember that your post-test is not graded. You may now turn off the video and complete the post-test. Welcome back. Now we'll review the questions and the answers to the post-test. Number 1, challenging behaviors of the resident with dementia may be caused by D, all of the above: a resident's physical and emotional health, the environment, and the method of communication that is used. Number 2, when a resident with dementia is angry or agitated. C, make sure the environment is quiet and approach them calmly, talking in a soothing voice, reassuring them. Number 3, when a resident with dementia has an incontinence problem. B, observe the resident's toileting pattern and try to toilet them right before their expected time. Number 4, in the resident with dementia, a challenging behavior that occurs at bath time could be due to D, all of the above: changes in sensation the resident has that the water causes due to the damage in their brain, embarrassment and lack of privacy, fear of water. Number 5, when assisting a resident with dementia in getting dressed, D, all of the above. Give the resident simple choices. Would you like to wear the red dress or the blue dress? Break the task into small, simple steps. Allow the resident to do as much as they are able to for themselves. Number 6, the most appropriate mealtime eating environment for the resident with dementia would be C, quiet, free from clutter and distractions, with simple place settings. Number 7, if a resident with dementia is not sleeping at night, B, try to prevent daytime napping and make sure that the resident is getting enough exercise. Number 8, when wandering becomes a challenge in the resident with dementia, C, take the resident for a walk or distract him with a favorite food or activity. Number 9, a resident with dementia who is unable to express a need of hunger or having to go to the bathroom or emotion of fear or sadness may respond with a challenging behavior such as D, all of the above, repetitive actions, screaming or verbal noises, wanting to go home. Number 10, when you're faced with a challenging behavior, it's important to D, all of the above. Keep a log of when the behavior occurs and try to pinpoint a specific cause. Review the 4 possible causes of challenging behavior. Develop a list of possible responses to the challenging behavior that have been helpful in the past. This concludes the challenging behaviors in the CBRF unit. And Robin and I would like to thank you for the opportunity of sharing some of our insight with you.